Our first speaker is Dr. Cliff Hudis. He is the Chief of Breast Cancer Medicine Services at Memorial Sloan Kettering Cancer Center, as well as President-elect of the American Society of Clinical Oncology, and the author of numerous scientific and scholarly articles and other accolades. He did his medical training and internal medicine training at the Medical College of Pennsylvania and his medical oncology fellowship at the Memorial Sloan Kettering Cancer Center. We are very fortunate to have him here discussing new treatments for breast cancer.
Great. Thanks very much. It's a treat and a pleasure to join all of you here today. I just want to apologize. I feel great, but I'm recovering from a bad cold, and I'm deaf in my right ear, and I have about 50% on the left. So if I don't like your questions, I'm going to ignore them and pretend that I can't hear you. But one effect is that I think I'm talking louder than I am, so everybody says for the last 3 days that they can't hear me. So let me know if you can't. I'm going to talk about a selected number of recent advances in the systemic treatment of breast cancer because, as you know well, there are days and days long symposia looking at this one topic. I have to editorialize to a degree, meaning I have to select only certain topics. There's no way to cover everything in 45 minutes or so. So forgive me if I don't touch on the thing that you find most compelling right now, but during the questions and the cases, I bet we'll have a chance to have those come up. I'm going to go through, in terms of systemic therapy, 3 broad categories, which do overlap a little bit, but I'll try to keep them separate. First, risk and prevention, and I'm going to highlight an emerging, but I think modifiable risk factor that we need to think carefully about. I'm going to talk a little bit about some recent developments in adjuvant systemic therapy, focusing on chemotherapy, because in the adjuvant setting, in the last 2 or 3 years, that's where the biggest changes have been. And then I'm going to end with a review of 2 topics in metastatic disease, one very practical and important, the other extremely arcane, but interesting scientifically. So, risk and prevention. The risk factors for breast cancer are well known to this audience, gender being the number 1 risk, and the number 2 one being age. And I say this because how many of your patients walk in and say, I don't understand why I got breast cancer? You know, at 38, the answer is a little more complicated, but at 68, the answer is actually because you got old enough to get breast cancer, just like most men get prostate cancer. In fact, most women don't get breast cancer, but a sizable fraction actually do if we detect it. Race is sometimes listed as a risk factor for breast cancer, and in particular for high-grade breast cancer, although in the United States and in other places it's confounded by socioeconomic factors that themselves are also associated with higher risk. I'm always reminded of Otis Browley's comment that in Scotland, which is a homogeneous population, high-grade triple-negative breast cancers are more common in the lowest socioeconomic groups, but the genetic diversity of the population is relatively limited. So there is something else going on there, and it may be that in the U.S. race is a surrogate and no more for those factors rather than being physiologically or biologically involved. I'm going to focus a lot on diet in just a moment, but to start this, the key thing is that there are epidemiologic studies associating high-fat diets with breast cancer risk. They are confounded by the fact that high-fat diets are associated with increased body mass index, and we'll come to that. Early onset of menses and late menopause are frequently cited risk factors. The ticket there, though, to keep in mind is that they are really good markers of a remarkably successful society, because girls have a genomic profile that leads to a germline profile that leads to a potential for menses, and if you're well nourished, you'll get your period sooner and you'll keep it later in life. And so you have to think carefully about whether you'd ever want to reverse that. Associated with that is the reliable delivery of children when you're pregnant and their successful growth to adulthood. That's a relatively modern phenomenon. And so as a consequence, we have late first pregnancies and fewer pregnancies because we're more successful with them. Again, I only mention this to point out that these moderate risk factors for breast cancer may well be important indicators of a society's general well-being. And so lamenting them is maybe missing the point. You want to undo the underlying consequences, but you don't necessarily want to turn the clock back. And these others are, frequently discussed, but certainly a little more controversial. BRCA is an entirely separate topic, which I won't touch on today. This is the topic. So this is CDC data, and these are the percentage of the residents of each of the 50 United States, segregated by body mass index, and plotted for 3 distinct years over 2 decades. There's a cartoon version of this that you can watch on the CDC website, or you can download the whole PowerPoint presentation, but this summarizes it fine. In 1990, roughly, close to half of the states had 10 to 14% of their citizens with a body mass index in the morbid obese category, which is a BMI above 30, or 30 or above. Remember that overweight is 25 to 30, ideal weight is typically 18 to 25, and underweight is below 18. Notice what happens over these decades. Now, this is not because of some evil plot. The fact is that Americans are consuming about 20% more calories per day in this last decade than they were in the 1950s. The average American now weighs about 20 pounds more than they did way back when. And echoing my earlier comments about risk factors, this is a reflection of a phenomenal success. We may be the world's greatest converters of sunlight into energy that we can eat ever. So we do a great job of growing and building highly caloric foods and distributing them and selling them cheaply. But physics being physics, and man neither creating nor destroying matter and energy, we're stuck with the consequences, which is if we eat 20% more calories per day than we used to, either we're going to have to do 20% more activity, and we don't, or we're going to store that energy. And there it is. So you'll hear endless debates about the kind of diet that people consume. I'm going to touch on that maybe for a minute. But the big issue, I'm sorry to say, isn't the kind of diet. It is the amount of food. And the only solution is going to be to change it. And again, each person has their explanation. But here's 2010. I want to point out to you, 30% of the residents of these states are now morbidly obese, and the number's pushing towards 40% is the expectation when the next plot is done. And you can see that there's no state at the beginning of this decade where fewer than 20% of the population isn't morbidly obese. So this is different. It is not like it's always been. People look back with rose-colored glasses at their idyllic childhood in the 1950s. I can't comment on that, but I can say that this is different. This is not the way it was. So what are the consequences? Increased BMI is associated with an increased risk of breast cancer in the postmenopausal state. This is important because it is not associated in the premenopausal state. So something's different at menopause in terms of the consequences of body mass index rising. And it's pretty linear across these deciles, as you can see. This is splitting the population into tenths, and the higher the BMI, the higher the relative risk of breast cancer postmenopausal. So while you think about the fact that this is seen and a premenopausal impact is much less clear, ask yourself this other question, which we've all been riddling on rounds for our whole careers. If estrogen is the primary driver of postmenopausal ER-positive breast cancer, the most common subtype of breast cancer, exactly why is it that the risk of that disease goes up when the serum circulating estradiol goes down? So the peak incidence is in the 6th and 7th decades of life when most people are in menopause. And we hand wave it. What did we all learn? We learned that obesity is associated with an increased estrogen production. I didn't touch anything, I swear. But this happened before. I'm a little nervous about the screen. Anyway, my hands were gesticulating here. They weren't touching anything. So, and so this is a little paradox that we've explained to our fellows and others by saying, okay, adipocytes make estrogen, but we don't explain exactly why. So this is the simple pathway that people are used to thinking about. Obesity, big adipocytes that make estrogen, increased estradiol, and that's the answer to my riddle. More recently, there's been a lot of attention paid to this pathway, which is type 2 diabetes, essentially. With the increasing incidence of relative insulin resistance, type 2 diabetes associated with increased weight, what happens is the insulin-like growth factor receptor pathway is upregulated, and there are lots of downstream consequences of that, including ultimately angiogenesis and cell proliferation. The third component, though, which is increasingly understood, is that there are adipokine and cytokine production changes leading ultimately to increases in pro-inflammatory mediators. And that led our group, in collaboration with Andrew Dannenberg at Weill Cornell Medical Center, to start asking, could we model this? And most importantly, could we consider a specific diet that would reduce these inflammatory mediators? So, to begin doing this, and this is why you want to have laboratory and clinical collaborations, the lab planned to take some female mice and to randomize them to a low-fat diet, 10% of the kilocalories coming from fat, or a high-fat diet. And the clinicians in the room said, what age do the mice go to menopause? Does anybody know when a black C57 mice goes to menopause? It's sort of a trick question. Anybody on the panel know the answer to that question? I didn't. It turns out they don't. So they die still potentially fertile. And so you have to model it, and the way you do it is, of course, do an oophorectomy. So that led to 4 groups. Half of them had an oophorectomy, and half of them got low-fat diet versus high-fat diet. The inflammatory mediators that we were trying to model reacted accordingly. So this is the mammary gland and the visceral fat from these mice, and these are TNF-alpha, IL-1 beta, and COX-2 expression. The lab is particularly COX-2 centric. That's been a decades-long focus. And what you see is low-fat oophorectomy, high-fat oophorectomy. All these plots show the same thing, that for each of the inflammatory mediators in both the mammary gland and the visceral fat, the greatest inflammatory mediator increase is seen in the high-fat oophorectomized animal. Why do we care? We care because a target gene of this inflammatory cascade, well established, is CYP19, the aromatase gene. So you turn on this inflammatory cascade and you upregulate CYP19, you upregulate aromatase, and that's what's shown here. This is expression, this is activity, and you can see it goes up in the high-fat oophorectomized mouse, both in the mammary gland and the visceral fat. And as you know, aromatase is the rate-limiting enzyme for the production of estrogen. It is the target, of course, of the widely used aromatase inhibitors. So, this provides a beginning explanation for the association of obesity and postmenopausal breast cancer. Simply put, with obesity, there's a subclinical inflammation turning on aromatase and providing local estradiol that you don't necessarily even detect in the circulation, providing the fuel for the ER-positive breast cancers. And I can go into an hour-long story here, but we have PR upregulation. We know that estradiol is generated because PR is a target gene, and so on. So it's real. Now, everybody who's been through menopause complains about weight gain, right? It's a known association. And the mouse mimics this. Here's the low-fat oophorectomized mouse compared to the low-fat, high-fat diet, and high-fat with oophorectomy, and the weights of the mice go up. So, again, the model has some reproducibility. What we then saw on histologic sectioning was this structure, and this is called a crown-like structure because it looks like a crown to the pathologist. It consists of a dying, overstretched central adipocyte, and because it's dying, it has emitted cytokines and chemokines that draw in macrophages, and they surround it to, of course, phagocytize it. The concentration of these lesions mirrored the concentration of the inflammatory markers that I already described to you. High-fat oophorectomized animal, this is the mammary gland, and this is the visceral fat. The scale's different here to here because the concentration is greater in the mammary gland, but this is the source of those pro-inflammatory mediators. This is a histologic lesion, and we said we are so smart, nobody's ever seen this before, we're going to go right to Stockholm and get our Nobel Prize. Turns out, we don't know the literature. The diabetes and endocrinology experts have known about the crown-like structure and given it its name forever. Apparently, it's commonly observed that there is low-grade chronic inflammation in the abdominal fat of diabetics and other, or especially type 2 diabetics. And it's kind of a passing interest to the endocrine world. So it's a known structure. All we did is discover something that was well described by others elsewhere. The only subtlety is it had never been described in the breast, and the aromatase connection hadn't been fully fleshed out in the past. So we went to humans. And Patrick Morris, who's a graduating senior fellow in our program, collected 30 specimens with Monica Morrow from people who were having risk-reducing mastectomies or contralateral mastectomies, and we took these from areas of the breast that didn't have cancer. A few of the patients had histories of cancer. Reflecting our population in New York, 7 out of these 30 patients were BRCA mutation carriers. That's why they were having risk-reducing surgery. But for the moment, we'll put that aside. And this is the structure by H&E, and here it is with a CD68 stain that brings out the macrophages better. But of course, this is the key, isn't it? 1 of 12 lean women have the structure on our routine surveillance for it, and most, but not all, of the overweight and obese by BMI category have it. So I want to make a couple of points about this. One, obesity is frequently associated with this inflammatory lesion in humans, just like the animal. It is, however, not always associated. This has tremendous implications as we think about the design of prevention and intervention studies in the future. It means that simply measuring height and weight won't necessarily enrich the population that we want to target adequately to test moderately effective drugs, for example. It means that some people, and we've done this now many larger cohorts, and it's holding steady, the ratio. Some people will have a kind of healthier obesity, which I don't like as a politically correct statement, but it is out there. But if they don't have the inflammation, then targeting the inflammatory aspects of obesity won't matter for them. The other point to make, and I can't make this clearly enough, is that the breast cancer consequence of obesity might be the 10th, 12th, or 15th reason on the list of reasons not to be obese. But the inflammatory cascade and its singular effect on aromatase and ER-positive breast cancer is like a canary in the coal mine. You can only imagine the chronic damage that this obesity is doing in terms of osteoarthritis, coronary artery disease, and so on. So this is a kind of a tip of the iceberg, and while we as cancer doctors tend to focus on our area of interest, our suspicion is that this inflammatory lesion, this chronic low-grade smoldering inflammation, may underlie much of the health consequences of obesity, and it may be addressable. I'm going to leave it for now, but I'm going to tell you that we have intervention studies involving diet under controlled circumstances at Rockefeller University. We have a nationwide prevention study using a fish oil, DHA, that's widely used because it blocks the toll-like receptor 4, and in our preclinical models, it down-regulates the inflammatory consequences. Now, the naysayers in the audience will say, well, Cliff, why don't you just put everybody on a diet and not worry about interventions? I couldn't agree more, except it doesn't work as a public health measure. And the New England Journal had a nice review of this topic a couple of weeks back, which I think is worth taking a look at. It's an intensely challenging behavioral issue, and I don't have an easy answer for it. And so we are looking at ways to mitigate the unfortunate consequences of what is now becoming the new normal in the United States. I'm switching gears to talk about adjuvant therapy. One has to start, when talking about adjuvant therapy, with the Early Breast Cancer Trialists Collaborative Group, the so-called Oxford Overview. Just, again, by way of introduction, and if you don't appreciate this yet, I like the intersection of social or societal issues and what we do, because I think it both enlivens the discussion and it gives us a different kind of meaning. The Oxford Overview was born out of an observation that in Great Britain through the 1970s, the survival of women with early-stage breast cancer and into the 80s was essentially no different than it was in Bosnia during its civil war. So while Britain, a rich country, had access to health care and interventions, lack of consistent application and understanding of what the data said about early breast cancer led to compromises in outcome. In fact, when Tony Blair ran for office, one of his campaign planks was specific to improving outcomes for breast cancer. So in that environment, Richard Peto, now knighted for this work, organized the Oxford Overview analysis, which took place every 5 years at England, and he applied essentially the same tools that he applied to issues like hypertension control, smoking cessation efforts, and malaria control around the world. The meta-analysis. He took all of the prospective properly conducted, randomized clinical trials done around the world where the investigators would give him the raw data and where survival was a primary outcome. And he put together studies of similar, though not necessarily identical, design in order to diminish the confidence intervals, make them tighter, and come up with a kind of average bottom line for treatment. And this settled a large number of debates that were always raging in those days. If you went to tumor board in the late 70s, early 80s, then Sylvia's colleagues' papers from Milan would be cited as CMF is the greatest thing since sliced bread. It lowers the risk of recurrence 50%. And then the next person at tumor board would find the Scandinavian paper where if you got CMF, your risk of recurrence was actually elevated over baseline. An improbable but nonetheless published result. So what the analysis overview does,
I think you're right. I think it is the bull.
something's going. Anyway, what the overview does, you don't need the slide for this, but what the overview does is it takes these studies of similar design and it averages them by comparing all of the control arms against all of the research arms. And all I can say is that in doing this, you filter out the noise while you homogenize the results. And so for tamoxifen, there is on average a 40% relative risk reduction, and the studies are very, very homogeneous. You're going to have to stand here, I think, because we've lost the screen again. What do you do each time? I'll try and do it. House PC, projector. Okay. There must be a loose wire, or I have one of those karma things. I don't know. Anyway, so tamoxifen is a good place to start with the overview because tamoxifan's tamoxifen, and most of it came out of the same ICI factory in England for many decades. And so if you took 10 or 20 milligrams and even 40, it didn't make a big difference. 5 years of tamoxifen in people with ER-positive breast cancers, by the way, note the presence of the target, reduced the risk of recurrence 40%. Done deal. Didn't matter about age either. Combination chemo is a little trickier because the studies are very heterogeneous. The drugs vary, the doses vary, the schedules vary, the durations vary. Nonetheless, on average, and you'll notice the pretty tight confidence interval, there is a 24%, a one-quarter risk reduction when chemo is given. And for ovarian ablation, interestingly enough, very important in developing countries, there is a significant adjuvant benefit, but when you've given chemo, that benefit's not detectable. And that remains true today. That's where we are. By the way, who knows when ovarian ablation was first reported as effective therapy for breast cancer? Anybody on the panel? I won't call on you. I'm just curious who remembers. I don't like when medical oncologists have to pay homage to the surgeons for starting their field, but that's what happened. Beatson, a Scottish surgeon, took ovaries out in women with locally advanced breast cancer and published this in 1896. He couldn't assay the ER, so lots of them had ER-negative disease, but some of them really did respond. He didn't have very good, good clinical practice, so the research methods weren't the same now, and it's clear that he selected his cases for his reports. But some of these patients had real regressions of their locally advanced breast cancers. That's the beginning, as far as I know, of real modern medical oncology with bilateral oophorectomy for early-stage breast cancer. It's more than 100 years later, and we still haven't resolved this question. So, I subtly made a point just now, but I want to emphasize it. ER-positive breast cancers, the presence of the ER marker tells you two things your patients care about the first. They ask, Doc, what's my prognosis? But you as clinicians care about the second. What is its predictive value? Knowing that somebody has a better or worse prognosis for systemic therapy is becoming much less critical than knowing whether a specific treatment will change that prognosis. And we are very precise semantically in distinguishing the word prognosis from the word prediction. So ER is a good prognostic factor, but it's a good predictor of tamoxifen effect, right? HER2, in contrast, which we'll get to later, is a poor prognostic factor predicting a worse outcome, but it's a great predictor of outcome if you give trastuzumab or HER2-directed therapies. For chemotherapy, that kind of predictive tool was lacking. And the problem is when I show you a 24% risk reduction on average for breast cancer patients treated with chemo, there's been no selection process. It's all comers. And it's pretty easy to imagine that some patients that you might be able to identify have chemo-insensitive disease and get Zippo, while others get a large benefit. And that brings me to this test, which has a brand name, Oncotype DX. In the interest of full disclosure, once upon a time I helped to develop it, and I had options in this company. I don't anymore. They've all gone since 2008. I have no conflict of interest. And anyway, when you hear what I have to say, you can see that they wouldn't have accused me of that anyway. So this test was an answer to the question, can I use the patient's gene expression in order to determine prognosis? That's the first question they asked. They looked at genes that essentially quantify S phase, genes that quantify the estrogen receptor, genes that quantify HER2, and a couple of others. And they compared these 16 genes in their expression by measuring their messenger RNA in preserved paraffin-embedded tissue against 5 reference genes, and they translate this numerically using a black box into a number on a 100-point scale. This is the recurrence score, which you all use all the time, and they arbitrarily, let us say that, arbitrarily divide low risk, intermediate risk, and high risk. And they get this plot using the NSABP B14 data. So they went back to B14, which was an old randomized trial of tamoxifen or not. They took ER positive, node negative, mostly postmenopausal women, all of whom were on tamoxifen. And then they asked, with this multi-$1,000 test, can I get a better estimate of their prognosis? And the answer was yes. If they had a high score, they had a higher risk of recurrence, and if they had a low score, they had a lower risk of recurrence. So tell me how this is useful. Ms. Smith is 68 years old. She has a 1.5 centimeter node negative ER positive breast cancer. You've written your prescription for a aromatase inhibitor, and you've guessed in doing that her risk of recurrence was, let's say, 15%. You spend a couple $1,000 and you get back a result that says, Dr. Hudis, you're wrong. Her risk of recurrence is only 12%. Dr. Hudis, you're wrong. Her risk of recurrence is 18%. What do you do next? This is important. You want a predictive test. You really don't need another prognostic test in breast cancer. So they went back retrospectively. After that had been published in the New England Journal, they took a later NSABP study, B20. This was a landmark study, by the way. In this study, patients got randomized to tamoxifen alone or tamoxifen with chemo, even though they had low-risk node-negative disease. And from 1990, that's how long ago, when this study was reported, we practiced based upon these results. We gave chemo to most patients with tumors above a centimeter who had, even with negative nodes, and even though they were getting tamoxifen. So what happened was, with flaws, it's a subset analysis conducted retrospectively, the low scores, there's no difference in outcome with or without chemo. High scores, it looks like there is. So what you're seeing is the evolution in how you think about breast cancer risk and the assignment to chemotherapy. I was taught risk equals benefit from chemo. High risk, big benefit, low risk, no benefit. And what this test changes for us just a little is it says anatomic risk can vary widely, but the sensitivity to chemo is on a different axis. So here's the concrete way to think about it. Ms. Smith comes to see you with an invasive lobular cancer, 3.5 centimeters in size, and 12 involved axillary lymph nodes. 100% ER, 95% PR, negative HER2. So while we all conventionally give that person chemotherapy and then give them hormone therapy, here's your future. You get a test like the Oncotype, and you get back a recurrence score of 7. You say to Ms. Smith, the bad news is this is high-risk disease, and the not-so-good news is chemo won't help that. So as shocking as that feels, you don't give trastuzumab to somebody for 12 positive nodes. You give it because HER2 is present, and you don't give Ms. Smith an aromatase inhibitor without ER. So you're just starting to see that change in chemo, and change is hard, and this is not fully validated yet. So Taylor X, Joe Sperano is the PI for ECOG, puts this in play. In this study, which I apologize for being blurry, but it's a straightforward assignment, 10,000 patients went into the study already. It's closed. If they had a high score, they were assigned without randomization to chemotherapy and their hormone. A low score, they were just assigned to hormone therapy. And in the intermediate zone, they got chemo as a control arm, and the experimental arm was the omission of chemo. And I've chosen my description of this with precision because you don't know the answer to the study yet, but the study's designed with the assumption of a chemo benefit and the hypothesis that you might be able to not use chemo. That helps you a little bit today while there's uncertainty. The other point to make is the scores were set at 11 to 25, not 18 to 31, because you can set them where you want. And remember that the mortality for breast cancer has been falling since 1990, and so we are conservative. Same thing is happening in node-positive disease, a subtle tweak on the design. But even with positive lymph nodes now, a very well-accruing study called RxPonder from MD Anderson and SWOG, Anne-Marie Gonzalez is the PI, is taking people with 1 to 3 involved lymph nodes, a group of people you have a knee-jerk reflex to give adjuvant chemo to, and if their scores are below 25, they are randomized to withhold the chemo or not. Now, the subtle problem with these studies is they're not really advancing the cure of breast cancer. What they're doing is ultimately is using the test to diminish the morbidity of treatment. And that's a little frustrating on the one hand, but on the other, we don't want to use drugs where they don't work. And that's where we'll get to. Now, there are many chemotherapy options, and I'm just going to remind you that there's a kind of an even tier first generation. These have been shown in randomized trials to be equal. There's a second generation, longer cycles of anthracycline, more cycles, or the addition of the taxanes. There's kind of a second and a half with better regimens, and these taxanes give it a more optimized strategy. TC is better than AC times 4. I mention that because it comes up in clinical cases all the time, but I want to point out to you that it's never been better than an anthracycline-containing modern regimen, and in fact, I'm about to show you that it's definitely not. And then there's dose dance and AC with weekly paclitaxel. So a couple of updates, both from Sandy Swain, our current president of ASCO. B30, 8 cycles of chemotherapy for node-positive breast cancer, AC, then docetaxel, or AT or TAC. No differences essentially for the latter two, but the 8 cycles of therapy was statistically significantly better than the 4. I mention this because there's a big move to TC, and to believe that this study doesn't matter is to argue that TAC is inferior to TC. And I don't believe that for a nanosecond. Adding adriamycin into TC, docetaxel and cyclophosphamide, does not make it less effective. At worst, it's the same. And in that case, it is inferior to 8 cycles of an anthracycline-based modern regimen. And mind you, AC docetaxel used here is not the best anthracycline-containing regimen. It's not dose-dense at 2-week intervals, and it's not with weekly paclitaxel, either one of which would probably be better. We in the CLGB have been trying to answer this question about how little chemo we can get away with, and we designed this study. Larry Shulman is a PI, a 2x2 design. We actually gave people single-agent paclitaxel as adjuvant therapy, or we gave them AC. And because people thought this would be inadequate treatment, we randomized them for 6 cycles versus 4. Now, after all this crying about how hard this would be and how difficult it would be to randomize people to this inferior treatment, our members stopped randomizing because they said 6 cycles of therapy was just too much. So we dropped this part, leaving just the AC paclitaxel comparison for the end of the study. We have only reported thus far, and we just did this year, that 6 cycles is not superior. This is important because as a principle, it means that hammering away with, let's say, TC times 6, while it may be better than TC times 4, it may not be. What's funny about our data is if you really blow it up with a magnifying glass, the 6-cycle arm plot's a little bit below the 4. It just means that there's really no chance that 6 is better for these regimens. B38 was presented at ASCO just a couple of months ago. This is the TAC regimen, Q3, 6 cycles, or our dose-dense AC paclitaxel from the CLGB, or a third arm adding gemcitabine. Again, Sandy Swain presented this. And here it's a little more subtle because adding the gemcitabine to AC and paclitaxel did nothing. We actually knew that from an earlier study called Tango. And there was no meaningful difference between TAC and AC paclitaxel, but there was actually more acute toxicity with TAC with 5 on-study deaths. So nothing has beaten AC paclitaxel yet. That brings me to the trastuzumab component of all this, HER2 positive. These are the 6 big randomized trials that have fundamentally informed how we treat HER2 positive early stage breast cancer. There are some limits, very low risk but commonly seen in the clinic. Patients were not included here, so we don't have good randomized data for the 8 millimeter HER2 positive node negative patient. But indirectly we do. Fundamentally, giving trastuzumab overlapping with a taxane seems to be best, however you do it. And I'll leave that aside because that's well-known data and that sets the floor for us. So what's coming next? Well, we saw that a small molecule tyrosine kinase inhibitor lapatinib added to capecitabine was better than capecitabine alone in patients refractory to trastuzumab in the advanced setting. So we went right full bore into an 8,000 patient randomized trial called ALTO. Standard chemo was given, and then 4 kinds of anti-HER2 regimens. Standard, a year of trastuzumab, very avant-garde lapatinib, no antibody given at all. This random sequence of them of 12 weeks of trastuzumab and then most of a year of lapatinib, or this concurrent combination. And it's not unprecedented, but quite extraordinary to me was last summer, a clinical alert went out that this arm was closed early. It crossed the futility boundary for inferiority, and investigators were warned, or at least advised, to consider bringing these patients back and offering them the missed year of trastuzumab, suggesting that as a single agent, it's an active drug, but it is clearly less active than the antibody. That doesn't mean that this won't be great. It might be. We have some neoadjuvant data that suggests that. But it makes a point that we really do need prospective randomized data before we adopt any of these strategies. So what's coming next? Well, this is the Cleopatra trial in metastatic breast cancer, New England Journal of Medicine by Jose Basalga, just published this winter. In this trial, first-line metastatic HER2-positive breast cancer received docetaxel, trastuzumab, and then either a placebo or pertuzumab, and the results are striking. The already respectable 12-month median progression-free interval was taken 50% longer to 18 months. That's the first treatment for these patients, and that's the median. The overall survival was clearly improved, although it was an early look because there were very few deaths on the study. There were 69 deaths with pertuzumab and 96 deaths with placebo. And again, this is on a backbone of effective anti-HER2 therapy and chemotherapy. So pertuzumab is already well on its way in the adjuvant setting. This trial is called Affinity. I just picked this slide in the interest of time, but there are 2 chemotherapy options. About 8 different anthracycline-containing regimens can be used, or TC, the docetaxel carbo regimen from the BCRG. And these patients are randomized simply for trastuzumab and pertuzumab, or trastuzumab and placebo. So this recapitulates the design of Cleopatra, but now it's in the early stage setting. The good news is Cleopatra predicts we may see a big benefit here. The bad news is we're building very expensive adjuvant therapy with 2 monoclonal antibodies and chemo that can be expensive as well. What comes next after this? TDM1. This is cool. How many of you are familiar with this? Not so many. So trastuzumab is the monoclonal antibody, right? I've been talking about it for a couple minutes. It binds to the extracellular domain of HER2 down near the cell surface. By the way, pertuzumab can be given at the same time because it binds up high. Think of the oak tree by the roadside. Trastuzumab attaches to the trunk. Pertuzumab attaches to the branches of the receptor. So trastuzumab can be used as a homing device. What they've done is take a dissolvable linker and they've physically attached 4 or 5 molecules of an antimicrotubule agent to it called DM1. It's a maytansine derivative. This drug had a brief career in the 1970s into the 80s, but it's not deliverable systemically. It's too toxic as an antimicrotubule. But think about the beauty of this and the elegance. This drags the chemotherapy physically attached to the antibody to the HER2-positive breast cancer cell. It is endocytosed. The link is dissolved. The chemotherapy is delivered intracellularly. And it sounds almost too good to be true. What it results in is relatively non-toxic and reasonably effective therapy. It's not a miracle by any measure, but it does let you get away from a lot of the toxicity of conventional standard cytotoxic chemo. So Kim Blackwell and colleagues presented this in the plenary session of ASCO, just again in June. They took advanced breast cancer, HER2 positive, and they gave them TDM1, or they gave them that control from the prior study I started this segment off, capecitabine and lapatinib. And it was significantly better both in terms of progression-free survival, and we learned last week that it crossed the boundary for overall survival as well. This drug will go to the FDA later this year, and I would suspect that approval will follow And then what will follow is testing it in the adjuvant setting. Here's where it's going to become a challenge, though. It isn't clear that this drug will offer progression-free or overall survival advantages in early-stage breast cancer over something like AC, docetaxel, pertuzumab, trastuzumab. The advantage is going to be a marked reduction in toxicity, and that has not historically been a successful road to labeling. So it's going to be interesting to see how this plays out in the regulatory arena. So even though I spoke about metastatic disease for a few minutes just now, this is the part that's actually about metastatic disease, and I'm going to cover, like I said, two topics. The first one has general applicability. So there are a number of palliative chemotherapy drugs, well-developed, widely advertised, and broadly used in metastatic breast cancer for their palliative effect. Two of the more recent developments are albumin-bound paclitaxel. It is paclitaxel, but it's encapsulated within a water-soluble body, and essentially that allows you to give it without the usual cremophore and less worry, therefore, about hypersensitivity-like reactions. It is reputed to be superior to other standard palliative therapies like Q3-week paclitaxel and even docetaxel in large phase 2 randomized studies. The other drug recently launched is ixabepilone, a different kind of antimicrotubulation. Again, FDA approved based upon real activity, albeit a modest absolute impact, in very advanced disease with a high amount of prior treatment. So we, in the CLGB, led by Hope Rugo, the PI, wondered if all these no expensive drugs were really worth it. And so we ultimately, along with our colleagues in the North Central, led by Edith Perez and Dr. and Alvaro Moreno, designed a 3-arm randomized trial where weekly paclitaxel was a control, and patients were randomized to one or the other of these newer agents. Now, at that time, about 4 years ago, we thought everybody was going to be getting bevacizumab, and so all these patients got the anti-angiogenic as well. These data were shown by Hope at ASCO, and they're, I think, to somebody who hasn't been watching this, kind of shocking. This is old, cheap weekly paclitaxel for progression-free survival. This is albumin-bound paclitaxel, which is not superior, that's for sure. We don't prove it to be inferior, though. And this is ixabepilone, which actually makes a p-value for inferiority, even though that wasn't the purpose of the study. So these expensive drugs, which cost 20 to 50 times more, have different and sometimes greater toxicity, in the end are not beating old, cheap, generic paclitaxel. And in fact, and we were talking about this at lunch, no single agent has actually beaten weekly paclitaxel in any randomized comparison now. Now, I remember when paclitaxel was a billion-dollar-a-year drug, the single biggest selling drug in medical oncology. But now it's a generic drug. So from a comparative effectiveness point of view, from a cost effectiveness point of view, this turns out to be an important study. Again, disappointing because what you want to see are advances. But at least, if nothing else, we know that we can use much less expensive drugs and save society a lot of money while delivering maybe superior, certainly equivalent results. So I said there was an arcane topic I wanted to cover in the last few minutes, and this is just a little bit of fun with precision medicine. So the new term for personalized medicine is morphing into precision medicine. The current director of the NCI likes to point out that his father, a physician on Long Island, practiced personalized medicine. He knew his patients well and spent a lot of time with them. But what he's aiming for, Dr. Varmus, is precision medicine. Okay. So Ashley Doan, who was a pre-med student in our program, out of a music education background actually, was working up his resume so he could actually apply to med school. He was working with William Gerald, a pathologist at our place, and he basically performed cluster analysis on, or gene expression profiling via cluster analysis on a bunch of patients from Memorial. And he saw something that intrigued him, which was that while the ER negatives and the ER positives mostly segregated, there were a subset of the ER negatives that by expression analysis were clustering with the ER positives. And he did something called a principal component analysis, which is, again, a very nuanced topic beyond me, but ultimately they deduced that the likeliest explanation was that they, of course, had an endocrine driver, it just wasn't ER. And I want to be clear, I'm not showing you this, but mRNA for ER wasn't present, or PR, and IHC was negative. So these cells were not ER positive, but what they were was AR positive. These were androgen receptor positive breast cancers. Now, there's a theme to my talk, which is that we think we're very smart until we see how out of touch we are. AR is known in breast cancer for decades. It's not new. 60 to 80% of breast cancers that are ER positive have AR. Its role there is not known. But what Ashley did specifically in the ER negative, AR positive group was to find a cell model, a cell line that modeled this, and he demonstrated something important, which was a testosterone drove these, an anti-testosterone blocked them, and ER blockers did nothing. So these cells mirrored what we're seeing in the analysis of the human specimens, suggesting that a subset of breast cancers may be AR-driven. It's not just an innocent bystander. And so Tiffany Train and Michael Danso converted this into a study that became a translational breast cancer research consortium study for reasons that have to do with precision medicine. I'll get to this in a minute. And they basically tested an old, relatively inexpensive drug for men, bicalutamide, which is widely used in prostate cancer as an anti-AR agent. And the question was, will we see activity in these otherwise difficult to treat triple negatives? Remember, metastatic triple negative breast cancer, what's your treatment option? Chemo. Period. So anything that would be less toxic and have efficacy would be a potential advance. So this is the precision medicine point and the reason we needed the TB-CRC. Only 10% of triple negatives have AR. Triple negatives represent 20% of breast cancer. So only 2% of breast cancer patients are in this category. This becomes an impossible study to do at any single center, even one like MD Anderson or Memorial or Dana-Farber, let alone a smaller place. And we had to band together with 6 or so main institutions. We screened 450 patients with where we got consent for testing. 424 were able to be tested. AR was found in 51, a little above the 10%, but not much. It matches our previous experience. 28 went on study because the way we did this is we enrolled them, tested them, and waited for their disease to progress so we could put them on study. They didn't all progress on whatever they were on, or worse things happened. Of those, 26 turned out to be eligible. There were 2 that actually on central testing had ER. And basically what we saw was stable disease in 5, and by the way, including 1 person who had unresectable locally advanced breast cancer, got neoadjuvant dose-dense therapy, and was then inoperable, went on this trial and became operable, and she remains in that same surgically induced CR to this day. So the problem is, how do you do a randomized trial? How do you get a regulatory approval? How do you get past the phase 2 setting when you're talking about rare targets like this? And the lung cancer story that made the news over the weekend is a reflection of the same problem. If you end up taking common epithelial malignancies like breast, prostate, and lung and colon, and you subset them into 10, 50, 100 almost unique subsets, then your old model for big randomized phase 3 trials is going to grind to a halt. And your standard for regulatory approval will have to be something different. So in presenting this, I'm submitting it for publication. We take the aggressive stance that this data alone is enough to justify AR testing and a trial of an anti-AR agent for these patients. It's not that it's a cure. It isn't. It's that it's good palliation with non-toxic therapy. There are essentially no toxicities for bicalutamide in women. And we're not going to get past this point. So if we can't agree that a little bit of phase 2 data does the job in this unique subset, then we're not going to be able to develop anything. We're actually looking at MDV 3100 as well as abiraterone in collaboration with the TB-CRC and a French group. So the world has decided that this is worthy of pursuit, but all of this will be non-randomized phase 2, and all of this will be multi-center. So here's what I've tried to leave you with today. One of the many consequences of the growing problem of overweight and obesity in the U.S. may include breast cancer. We think we provide part of the explanation for why ER-positive postmenopausal breast cancer rises in response to obesity. But this is a modifiable risk factor, and we're endeavoring to develop those modifiers. Adjuvant therapy, the bottom line is it's becoming more selective. One size doesn't fit all. Anatomy will not forever drive the choice of chemotherapy. Increasingly, you will use biological predictors of chemosensitivity. Whether we're there or not right now is a judgment call. We have reasonable confidence in node-negative disease with one test. We're going to have a lot more data in the next few years. And then newer palliative chemotherapy agents, regrettably, are not necessarily superior, and some of the newer agents, like the anti-androgen approach, but there will be many others, are going to require a new approach to drug development. Thank you.
Thank you. I've got a question. In one of the Lancet editorials, there was a term used as relative chemoresistance, and 3 topics. One was ER-positive patients, triple-negative, and HER2-positive patients.
Right.
Your data showed that the benefit of chemotherapy is heterogeneous, 24%. How about one of the questions you did not mention is, does everybody need adriamycin?
Is it what?
Adriamycin.
Yes.
And is there a selectiveness depending on which coast you come from?
So this is, let me repeat the question, make sure I have it right, is are there tools to allow us to do a better job of selecting patients for or against anthracycline use in the adjuvant setting? And the reason I left it out is it's A, heated topic, B, we're going to talk about this Saturday at ASCO, and C, I don't think there are, period. So there are experimental efforts using topoisomerase 2A by IHC or by FISH, but the testing is not validated, and I personally don't use anything to select this except general health and comorbidities, and I just don't think we're able to do better than that right now. Some of you will disagree, I'm sure.
A question based on SWOG 8814.
Yep.
Should we be getting Oncotype DX in our node-positive patients? And then if we do, for example, if you have a postmenopausal ER-positive, node-positive patient and you get a low recurrence score, you're not giving chemotherapy.
So this is a great question, and I sidestepped it by showing you the R-Exponder randomized trial. For those of you that don't know, I showed you the node-negative experiment where retrospectively in about a quarter of the patients blocks were available. For that quarter of the population in the study, the results reflected the overall study, chemo added. Then in that same cohort of patients, the oncotype segregated them. The same experiment was done with a node-positive trial from the 1980s, 88, that's the year of the study, 14, in which people got tamoxifen alone or tamoxifen and CAF. This is the pre-taxane era. Some of you will remember that trial because it suggested that giving tamoxifen and chemo at the same time was not advantageous, whereas the sequence was. So they only compared 2 of the 3 arms. They only got about 20% of the specimens. I'm a co-author in that paper. And it looks like it does the same thing in the node positives as in node negatives. That is, a low score, no benefit for the CAF, high score, benefit. So your question, which is a critical one, is with those 2 retrospective and limited analyses, do we have the confidence to put something like oncotype first and anatomy second? And I think that right now the answer is probably not. From an evidence-based point of view, I don't think we're there. That said, if Ms. Smith, I have a lot of Ms. Smiths, shows up in my clinic and is 39 years old with 2 positive lymph nodes, ER positive, I'm not getting an oncotype. I'm going to treat her. But let's make her 68, give her some type 2 diabetes and a little bit of osteoarthritis, and she's walking with a cane. I may get the oncotype for that patient, and I will preset a score where I'd be comfortable not giving chemo. For example, below 11. That's not their score. It's the one I can live with. Here's a converse situation. Ms. Smith calls you up. She's 39 years old, and she has a 7 millimeter cancer, ER positive. And she says, I want to get an oncotype. And you say, why? She says, because I don't want to leave any stone unturned. In that setting, a very high score, above 31, might push me to give chemo where I normally wouldn't have. Now, in neither of those settings do I actually have data yet. And we all have to practice right now, even without it. But the results have been pretty consistent for predicting the benefit of chemo in those 2 studies. And that's all we have. And we'll see what Taylor X and R-Exponder show. So, without that, it actually came up for me this week, as a matter of fact. A friend's mother is in the Midwest, not in New York, and contacted me with a 1-node positive breast cancer and a 68-year-old with Parkinson's disease. and got an oncotype of 12. It was sent at an academic institution asking, what should I do? And both her doctor and I agreed that for her, it was probably reasonable using the 12 to pass on the chemotherapy. I think that's where we're going to end up, but I can't say that we are there yet, and you can't encode that as a guideline yet. We're not there. So I hope I'm not too wishy-washy in trying to answer it. It's a tough question right now. Change is hard.
I have
For the TDMS study you showed us from ASCO this year.
Yes.
Was there a study or maybe an error at the same study ASCO of last year that wasn't really a breakthrough or no? There was a paper presented at ASCO last year?
So there have been a number. This is about the development of TDM, and I showed you the phase 3 randomized trial, which is the pivotal study that they've designed to get drug approval. Really, all the data for TDM has been very promising. I think I know what you're referring to. In the phase 1 setting, there were responses in heavily pretreated patients. That's a signal. In the phase 2 setting, they did a non-randomized trial where they took patients, follow me, AJ refractory, taxane pretreated, capecitabine pretreated, trastuzumab pretreated, lapatinib pretreated, and they got a response rate. And they tried to get FDA approval based upon that non-randomized study with a fast track last summer, and they were shot down. I wonder if that's what you're remembering. Yeah. Yeah. So we thought they might even get it because that kind of activity, they had, I think, maybe fudging at 18 or 24% response rate. It was pretty striking for that heavily pretreated group of patients, and it seemed like a no-brainer to some people that it should be approved based upon that. But it wasn't, and here we are.
So I'm going to ask a question about hormone therapy, which you started the talk with, and it's interesting. We know that there's no benefit for 10 years versus 5 years of tamoxifen, but what we have seen is the addition of aromatase inhibitors after tamoxifen, and it seems like there's some controversy in how long they should be continued 2, 3, 5 years after initial tamoxifen.
So I guess I did leave that out of my talk, but so you're right. 5 years of tamoxifen was better than 2 in the overview, and 10 years in one study and no negative disease wasn't better. It's actually not completely resolved about whether it would be better in higher risk disease, but put that aside. There have been some hints that it might be, but they didn't make statistical significance. The aromatase inhibitors were studied 3 ways: instead of tamoxifen, after tamoxifen, and in the middle, meaning starting at the 2nd to 3rd year. If you give 5 years of tamoxifen, 5 years of letrozole is currently standard. That's 10 years of therapy. If you give 2 or 3 years of tamoxifen and you make the switch to the aromatase inhibitor, in the trials they gave 2 to 3 years of the AI, making 5 years of therapy. But it's so hard to believe that 5 years of letrozole after tamoxifen is good, but you don't need the same 5 after just 2. So as a matter of convention, once we start AIs, we always plan on 5 years. The next part of this is MA17R for re-randomized. They took the people who got through the 10 years and others who had 5 years of AI exposure, and they've randomized them against placebo to get a second 5 years of the AI, which could mean 15 years of therapy. And it's cooking. So I don't know what to tell you right now in the clinic, right? Because there's no data. But there will be data. Just not tomorrow. All right. Well, thank you very much.